Hi, Ravi. Is anybody there? Hi, guys. Hi, everyone. Hopefully, can hear me. I'm just going to wait for another 2 or 3 minutes so that we have more participants, and then we can start the webinar. Thanks. I can see one like, so you can hear me. That's brilliant. Thank you. Could Oh, thanks. I can see someone typing in here. Just give me a thumbs up or just say yes if you can hear me. Okay, I'll start in 2 or 3 minutes. Thank you. Thank you very much. Brilliant. 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 I can see about 19 participants at the moment. So as I said, let's wait for 5 p.m. India time, and then I can start off. So hopefully people won't miss the beginning. That's my plan. I mean, as you all know, that we were planning to do this via Zoom so that it could be interactive and, people could see each other and people could chat. But unfortunately, um, there's been lots of issues around using Zoom in terms of technical sort of security, as well as issues internationally, not just nationally. And everyone's been recommended not to use Zoom, which is why I think Dr. Ravi had a bit of a struggle in the morning to sort of redo this via his live web stream. So I'm glad that you guys are joining me. I'm just going to check if Dr. Ravi is also online. Brilliant. Great. Let's kickstart our webinar today. So just to give you an overview, first of all, thank you very much for joining in. And I can understand that people are joining from India and probably a couple of other countries, so which is brilliant. And thanks very much for joining. As you know, we are in a very, very unprecedented kind of a difficult situation internationally, globally. We have never had such a challenge for the past 100 years. I think the last outbreak, as you know, was probably during the Spanish flu, about 1918. And after that, we've never had, apart from SARS, apart from MERS, if you all are familiar with these terms, SARS was severe acute respiratory syndrome, and MERS was the Middle Eastern respiratory syndrome, which all kind of threw similar symptoms in patients and also resulted in almost a global pandemic, but which was well controlled. So today, obviously, I thought it's useful to talk about COVID-19, useful to talk about how UK is doing, useful to talk about the European response, And I'm going to cover 3 and 4 things today. So first, I'm going to cover a little bit around the UK and the Europe response as to what's happening here. I'm sure people in India are looking at the news channels and wondering what's going on in Europe. You know, why is the rate so high, infection rate, death rate, etc. So I'll touch on that a little bit. The second, I will touch on the change in practice that we had to rapidly undergo in the primary care, which is in the GP setting, as well as in secondary care, which is in the hospital setting, as well as the critical care, which is in the ICU or ITU settings, as we call it. The other thing I want to touch on is the clinical trials that have rapidly started. And I'll mention a few that are directly related to management of COVID-19. Now, one of them, incidentally, is kind of started from India, where somebody used hydroxychloroquine for management. And we have actually established a study just to see the effects of that. And the last thing I'll touch on is a recovery plan, or resilience, as we call it. So, for example, this crisis is going to end eventually someday. And what happens next? You know, is it going to be a staged opening? How do we plan that? Of course, I'll talk from a UK perspective, but it kind of applies internationally to other places as well. So just to introduce myself very quickly, I'm Dr. Ashmore. I'm a public health specialist by profession. I have been in infection control departments, which we call CDC in the UK. I have worked as a public health specialist for long-term conditions, mainly diabetes, CVD, cancer, and COPD. I'm just guessing that everyone's health professional and familiar with these terms, so I won't detail them. I'm an honorary lecturer at Imperial College, where I teach public health student, masters, and PhD students. And our topics are covered from a range of issues, from prevention to protection to management of comorbidities and other conditions. So obviously our focus during the COVID-19 crisis was how to look after people with long-term conditions and comorbidities. So that's me. So let's start with the UK and the Europe and what really happened in UK and Europe. As you know, the outbreak really started in China. And I don't know if you guys, I'm sure you've interpreted by now that COVID-19, I presume, stands for CO is corona, V is virus, D is December, and 19 is 2019. So that's when the crisis actually started. Now, once this crisis started, people are asking questions about, did China take time to inform the WHO? Did China take time to inform the world about what was happening? We don't know the answers to that. But what we know is that because of global migration, the infection spread quite rapidly around the world. And that was the first reason why, I mean, as you know, Europe has a very large migration, very large influx of people from around the world. It's a commercial hub. Commercial hubs are including Germany, UK, France. We have Italy as well. And of course, there's huge traffic, air traffic from China, which is probably all over the world, not just Europe, in South America, North America, as well as Asia and Australia. So I think the first point of start was that, if you ask me, when was the first case of COVID detected in the UK? We knew about it in January, when the suspicion was alerted. Now, the public health professionals do find out about these things. They know that something is happening. So they keep informing. So in the UK, we have something you must have heard about, is a national health service, which means healthcare is provided free of charge to the population of the UK. And by that, so for example, in India, you have private medical care. In America, you have insurance-led medical care, same in India as well, and parts of Asia. But in UK, 95% of the care is provided free of charge. There is private medical care. There are private hospitals where people pay and get on. There is insurance as well. But I would say 90% of the population avails free healthcare, which means the responsibility of maintaining good healthcare rests with the NHS, or the National Health Service, which is managed in a way by the government. So basically, as you can see, I'm an NHS employee, which means I work for the government, and I work for all the trust and ensuring that healthcare is delivered in a very good form. Now, UK, just like many other countries and WHO, has a pandemic flu plan. Now, what that plan says is that it's about, what happens when an outbreak happens. The first thing is testing. There are stages. There's testing, there's contact tracing, there's quarantining, then there's retesting, and then there's release. So immediately, as soon as you realize that it is an outbreak, and outbreaks are in communities, are in clusters, are in care homes, are in a hospital, or it could be in the population. And depending on the size of the outbreak, control measures have been or had to be put in place. So the first thing that happened was the government pulled out their pandemic flu plan and immediately issued guidelines. Now I wanted to share links by share screen, but I couldn't. But if you just go to gov.uk/coronavirus, you'll find out a lot of these guidelines that have been provided by the UK government. So it's gov.uk, that's gov.uk/coronavirus. That's the first thing. So the guidelines started coming out quite quickly, and the guidelines were not just for people like, what do you do? Do you wear a mask or not? Do you go out or not? How do you interact? How is it getting transmitted? So a lot of us professionals put up small videos on screen just to let people know what the symptoms are, what to look out for, and how to take care of yourself. So there was a lot of efforts from all the healthcare professionals, the infection prevention guidelines, the NHS working day and night to roll out these guidelines to hospital settings, because there were three things to look out for. What happens in primary care? What happens if a patient steps into your clinic and you don't know whether the person has COVID or not? Because that is the first risk that a health professional has in terms of acquiring disease. The second thing was hospital settings. Now, there was a rapid change in practice, which I'm going to come to in a minute as to how the practice changed, but it was immediately prioritized to understand that because hospitals have a very high number of high-risk patients visiting. So how do you make sure that the staff is safe as well as the patients are safe? As normally people in hospitals don't walk around with masks. You would only wear a mask if you're in a surgical room, or in an ER, or if you are in an infection control, an infectious disease clinic. So it is not a routine practice. So the first point of call was to roll out guidelines. And you will find several guidelines on the NHS England website. And the other website I just wanted to tell you today was the NICE. If you haven't heard about NICE, it's basically National Institute for Care and Excellence in the UK, which sets out guidance and guidelines for healthcare professionals. And you, wherever you're in the world, you're welcome to use these guidelines. So if you go to nice.org.uk, nice.org.uk, you'll be able to see the various guidelines available. So NICE stepped in as well, and NICE said, here's rapid guidelines around how do you manage people with COPD amidst the COVID crisis. What if a person with chronic obstructive lung disease or pulmonary disease comes with COVID or without COVID? At what time do you think the case is severe enough to be admitted to a hospital? If a person ends up in a hospital, how quickly does the person need to be moved to an intensive care? Drop-in, so using pulse oximeters, so here we have something called as a news score, which is actually a scoring method, which, in ICUs, we use different methods for scoring and grading, like a Glasgow Coma scale and others. So here we have a news score, which is, I won't detail about it, but it basically tells us when a person is critical enough to be admitted to an ITU. So just concluding this first part about the UK and Europe, as you know, and I can read out a few statistics for you, is that right now in the UK, we have about 98,476 confirmed cases of coronavirus. And this is after testing more than 300,000 people. That means 1 in 3 are roughly getting confirmed. And who's getting tested? People who have symptoms or people who are presenting to healthcare settings, whether it's urgent care hospital settings or whether they're getting admitted. And now they're rolling out to care homes as well. Now, care homes are places where older people are looked after, people who have dementia, people who have other conditions, or people who are generally old, and they probably need a care home because they need some nursing care. So right now, out of the 98,476 confirmed cases of COVID, daily, we are seeing an increase between 3,500 to 4,500, which is quite significant. But remember, some of these are also getting better or recovering. Now, out of the 98,476, we have had about 12,868 deaths, which, as you can see, is a good 13-14%, if you call it a case fatality ratio. And the daily number of deaths in the UK are varying. It started off with obviously a low number, but it peaked to about 980 about a few days ago, which I consider as a peak based on our modeling. And yesterday, the death toll was 761, which is quite a high proportion. Now, remember that the number of deaths in a population are sort of subject to the age profile, who's getting in, also the comorbidity profile, which means how many long-term conditions a person has. Because if you have an existing lung conditions, you're 10 times more likely to have a severe acute respiratory distress, which may lead to atelectasis or lung collapse, which may lead to you obviously losing your life. So it's an age profile, it's the stage at which you present, whether how good is the testing in different countries, and all these factors in turn kind of, and of course the care that is provided. And I can say that around the world we have excellent care provision in all sorts of settings. So one last thing I wanted to tell you before we end the first session is that there are lots of trackers out there. As you know, the Johns Hopkins University have put out a global tracker for COVID. So if you just Google Johns Hopkins COVID tracker, you get this amazing global world map, including daily cases by country, by including the number of deaths. United Kingdom has also created a COVID tracker, and I know India also has a COVID tracker that they're using via the ICMR. Now, the thing here to note is that what we see in the trackers is what has been reported. But remember that there are cases in the community which may be asymptomatic. Younger people are less affected, or if they're affected, they may have less severe symptoms. So according to my knowledge, and this is just my knowledge, and don't quote me, it's not published data, but if you say that you have about, say, 100,000 cases, to me, I would multiply by 10 to say how many are likely to have been infected by the virus but may have not had any major symptoms, which means in the UK, my estimates would be that about 1 million cases would have had the virus, may have not shown significant symptoms because you're younger or you don't have any comorbidities. Similarly, in India, I haven't seen the latest statistics in India, but whatever the reporting is or whatever testing is happening, I'd be cautious in this, but you multiply roughly by 10. Now, it's not to scare people, but it's just to understand the extent, because based on that, the modeling is done. So, for example, if somebody contracts the virus, it takes about 7 to 8 days to get the symptoms. Now, after 7 to 8 days, it takes another few days to understand how severe it's going to get, depending on your personal health. And after that, a hospitalization, if it ensues, patients are ending in hospital between 7 and 21 days at the moment. But within those 7 days, if you end up on an ITU bed, our average at the moment is showing that a patient is in an ITU or ICU bed between 8 and 16 to 20 days. And if you need ventilator support, obviously that's almost 2 weeks. So your total hospital admission can be up to a month before you're actually discharged if everything goes to plan. So there are these trackers available. So do have a look, because very important is that how do you do discharge planning? How do you do post-discharge monitoring? What is quarantine regulations? How many? What are you going to tell the patient when he's leaving the hospital bed? You know, how long do they have to self-isolate if they have to within a family? What if their circumstances are such that they're living in a small house with 5 people in there? You know, what's the advice for other people if they don't have anywhere else to go? What's the advice on masks? You know, and our recommendation here was that any discharged patient, unless tested that they're negative, so the viral load has completely gone down and they're COVID negative, they were advised to hold caution, maintain distance between other family members, not go out, maybe even wear masks when talking to others, just to avoid that spread and use precautions. So that is sort of, I won't go to details about Germany, France, etc., but there is a difference between the mortality rate or the case fatality ratio. And I'm just working on a research project to understand the variation in global mortality rates from COVID-19. So I'm trying to do this as an international project. If anyone's interested, please contact Dr. Ravi Doctor, and we'll work on how to do the association, because it'll be very important to understand what happened in India and what's the death rate and what's happening. The second quick thing I wanted to touch on, and just to let you know, I didn't mention before, but I will talk for another 10 or 12 minutes, but then I will try to answer some questions that you can type in the chat if you have anything, okay? So we'll try to stick to time. So the second bit I wanted to talk to you about change in practice. What happened was that when the COVID crisis became peak in March, the first thing, what do you think of? If you have your private clinic, the first thing you think of is, if a COVID patient walks in, where am I going to put the patient? You know, how do I disinfect the area before the next person comes in, irrespective of the fact whether you have tested positive or not. Same thing applied to hospital settings. Same thing applied to primary care and urgent care settings, care homes, etc. So the first thing we did was we divided some of the clinics into COVID and non-COVID zones, which means anyone suspected of, you know, with a cough or with fever, headache, and suspected of having COVID-19 symptoms actually goes to a different area initially. And this happened in all of our settings, which means we completely changed the way we were working. The other thing was workforce prioritization, you know, moving staff around. People like podiatrists, you know, who normally look after feet, were actually roped in to help other things, because people with foot problems were not coming into the hospital because they were afraid they might catch COVID-19. So there was another worry for us about hopefully we're not missing very high risk people that are going in. The third thing was about guidelines. What guidelines do we quickly roll out to what do you call as an A&E? We call it here as an ER, which is emergency room, or accident and emergency trauma center. What guidelines we set out for inpatient care, so patient in a hospital bed. We had to isolate these zones clearly. And when we isolate, we had to give PPE recommendations to each area, because WHO has released, as you must have seen, but if you haven't, then just Google WHO PPE guidelines for COVID, and you will find out that WHO has clearly stated what PPE should be worn where, whether it's mask, whether it's screen, whether it's covering the eyes, whether it's the gown, or whether it's a full protective gear, because you know that a lot of the healthcare professionals are getting it, and some have unfortunately died as well. And one of the high-risk groups was people who were doing intervention in otolaryngology, or laryngoscopy, or any intervention procedure for the respiratory system, were at very high risk. So they have to, and even those in the ITU have to wear full PPE protective gear, especially those who are managing long-term conditions. Now, you might have seen on TV is that in Italy, in one of the hospitals, they actually created a zone. So, for example, there's an ITU of about 6 beds inside. They actually created a door within a door. So there was a completely hygienic, or what do you call, a disinfected area. So if there were injections being transferred from one section to another, so there was a person outside who was creating the medication, the IV, and he used to open the door, put it in the middle, close the door. The ITU person or the ITU nurse, the doctor would come in, open this door, take this injection, go out. There was complete separation of, so this actually helped lower the transmission to healthcare workers as well as transmission within the hospital. So this was the change in practice I wanted to highlight, which was rapidly done. And I'm sure all the hospitals around the world thought about this. Their infection prevention guidelines kicked in, and they've done a good job, actually, because the number of healthcare professionals, the percentage of healthcare professionals affected is very low. And that's a good sign that PPE is being used adequately. And the change in practice of COVID, non-COVID zones. So even now, I would recommend that in your clinics, in your other places, think about when a patient is coming in, think whether the person has symptoms of COVID and what you're going to do after the patient leaves or before the next one comes in. Of course, sometimes you may not have enough space within your clinic, but so then we have gone into video consultations. So we're doing quite a lot of video consultation with patients. We have Metapad, we have Accurex. We have lots of software that's been provided, not Zoom, because obviously that's not secure for clinical purposes and IG, information governance. So we used a lot of these things to triage patients. So it's very important. I know that some of the clinics rely on patients for their income, etc. But for now, it is very important to triage patients before the patient contact is made by the healthcare professionals. This is just to protect yourselves and ourselves and the patients as well from any transmissions. So this is the change in practice I wanted to briefly mention. Now, I'll move on to my third topic before we start any questions, is on clinical trials. Now, I don't know if you have seen on the internet or you've browsed around, but I can tell you that within UK itself, already we have 27 clinical trials officially registered via the UKRI, the Research Institute, or the MRC, which is Medical and Research Council, as well as through the NIHR, which is the National Institute for Health Research. Already 27 clinical trials registered. And the total number of studies that are registered are about 41. And there's a list online, and I can either try to send you the link, or if you Google Health Research Authority clinical trials for COVID-19, then you might get that link to the HRA website. Now, in the clinical trials, I just wanted to mention a few which may interest you as well. One of the trials we have started is called the Principal trial. So it's just called Principal. And this is for high-risk patients who are suspected of COVID-19 symptoms who present in primary care, so in GPs, clinics, and outpatients. This is exclusively for the drug hydroxychloroquine. The age and the criteria for this is people aged 50 to 64 years, mainly because they're high risk, they're older people, and with comorbidities, which means there are specific listed conditions that the patient should have. And of course, this trial will also include people who are age 65 and over without any illness, so that you're covering a broad cohort of patients and seeing the efficacy of hydroxychloroquine. This is called the Principal trial. So if you Google principaltrial.org, you'll be able to see the details of that. The second trial is the recovery trial. It's just called recovery. And this is an in-hospital trial. And this is for several purposes. So when a patient is coming in the hospital, they're going to try antivirals, they're going to try steroidal medicine, they're going to try hydroxychloroquine, as well as azithromycin, which is a normal antibiotic used for anti-COVID. The antivirals used are lopinavir and ritonavir, which are common anti-HIV drugs you might have heard about. Now, the recovery trial is purely for anyone over the age of 18 and hospitalized in the hospital. So if you Google recovery trial, you will be able to get the information related to that. Now, the third one is the REMAP CAP trial, so REMAP-CAP. And this is for the critically ill patients who are admitted to the intensive care unit. Now, this is a randomized adaptive trial because people will get multiple interventions. Some might get antibiotics, some might get antivirals, some might get ventilator support, but they're trying to evaluate the effect of certain medications on the outcome of a person with COVID admitted to critical care. There's no age bracket for this. So this is the third trial. And then there are a list of other public health trials underway, so I won't detail in them. If you have any other queries about this, do type in the box and I'll try to answer them. Now, the last part. So in 2 minutes, I'm going to tell you what is recovery and resilience, if you've heard the word. So recovery is obviously, as you know, I mean, I think majority of you guys are in India at the moment, and India is talking about pulling back the lockdown. What does it mean when you say pull back the lockdown? You know, what is staging? And what is, and where are the guidelines? Okay, nobody has seen them, you know, and I know that in many countries they're treating it as red and hot and cold zones. Some are calling them red zones, green zones, amber zones. Somewhere they're calling gold, bronze, silver. So there are several things given to, depending on the outbreak, depending on the cases. Now, in the UK, the government is currently developing a strategy, and it's called an exit strategy. So when you come out of the outbreak. Now, one thing you will agree with me is that once the country borders open, so even in India, most of the flights are grounded. It's only the repatriation flights that are underway. You're going to see a surge of global international travel. So people traveling from one place to another, which is going to lead to a spike in COVID-19 cases, as China has seen in Wuhan and other places, as South Korea has seen recently, as Hong Kong will see in a bit. And I think UK and Europe are also expecting the same. So we need to be very cautious about how much international travel is permitted within the next 2 months. That's one thing, because that's the second wave that we have to be alert and aware of. The third wave is going to be around winter flu, around December time. Because in December, as you know, it's a flu season, it's a winter season, most of the time in the northern hemisphere. And during that time, the seasonal flu kicks off. And the seasonal flu now is going to have the COVID-19 strain. You know, in the past, we have a H1N1 strain, H1N2, H5N5. We have had SARS. We have had the winter flu, which is a low intensity virus. And now we have a COVID-19, so COVID-19 strain. So in the winter season, which is around November, December, right up to February, we're going to see another spike. So healthcare services will have to be prepared again during the winter time for another surge. So coming back to the lockdown and the opening, I think it is very important to note here is that if in any case, the lockdown has to be considered from the point of view of not just how many number of cases of infections you're looking at, but how many are you expecting in the population. So I'm pretty sure that over the next 2 months, public gatherings would be avoided or will be banned at least till August, I think. They wouldn't be allowed. The other thing is whether we should wear mask or not. Now, a lot of the countries have come forward and says, use mask, you know, it's fine. UK has been a little cautious for a few reasons. One is they feel that people wearing masks, you know, you're breathing, so it becomes kind of humid. And people tend to touch their faces. And so they're afraid of cross transmission. And they're afraid whether this mask will actually not help. So is there, just keeping 2 meters distance, and they're already doing that in superstores and other places, and there are no people on the road. Would that be good enough? Shops are also not letting all people in at once. You know, they're making sure that there's 2 meters gap, so no one's talking to each other, or, you know, contact and transmission is also avoided. So that's the thing. The third is about technology. You know, how can we use technology? For example, you know, I know there's an app in India, there's a tracker here as well, and how safe it is to use and how good it is to understand. And is that going to result in, I mean, I'll be perfectly honest with you, when I heard about an app in India about through Bluetooth, you're going to find out if somebody has a COVID or not, that actually puts the other person at risk. The person might just be a threat to others, and you might just start a riot in the community. So I'm not sure if that app is a safe idea in certain ways. I know majority of the population is educated to understand what it is, but I think what's more important is to highlight zones on a map, which is what I'm working on right now. Is that if you give people an idea on the map about which are the hot cold zones or red, amber, green zones, people will avoid going there. And how do you identify that? Is by the Public Health England infection control data that the government is holding around hazard. So making people aware of where they can or they shouldn't go will actually reduce that infection spread. So that's one way we can use IT and technology apart from what we are doing already. And the other couple of things is media. The responsibility of the media as to how important it is to send out the right messages, like what we are doing today. It's a health professional chat, but what goes out to public is perceived in a completely different way. And that we also are very good advocates. So all of us on the chat right now, we're all advocates around good practice. So, and it shouldn't stop you from making your own video and putting it through a WhatsApp group or something, just to keep the awareness going. Avoid listening to fake news. Look out for useful news. I know there's lots happening, and lots of you must have already done these things, but I think it's important that we keep that message on. So I think those are the 4 things I wanted to cover today, which is the UK response, the changing practice, the clinical trials that are underway, and the recovery plan or the resilience, which I just talked about. So I think what I wanted to just ask you is that I think I'll stop here now, and thank you very much for listening. I can see the chats. There's lots of people are adding links about ICMR. Ravi has added quite a few links as well. So if you have any questions, please put that in the box, and I'm happy to answer them in the next 5 or 10 minutes, because I'm free for the next 5 or 10 minutes. And I'm just going to quickly go through the comments that people are typing in. Thank you. Somebody has put in the link for NICE, ICMR. Infection prevention guidelines, which is brilliant. International travel control, I kind of touched on. Right, so here's a question. Hotspot awareness, and very important to get the graph down. That's a very good thing. That's very important in current times. So there's a question here that if we keep doing lockdowns every time a strain of this virus hits during every flu season, then when and how does the public develop natural immunity to this virus? A very, very good question. Now, the reason behind lockdowns such as these, according to my knowledge, is that we want to reduce the death rate. That is number one. Because this virus, if you compare the case fatality ratios between this strain and other strains or other infectious diseases, this one has tenfold high mortality rate. And that was one of the significant reasons behind continuing lockdowns such as this, major lockdowns. And just imagine in a country that's got more than 1 billion people, if you kind of not put any controls, like Sweden initially did not put control, and you can see their case fatality ratio is 10%, which is sort of less than UK, but much higher than countries like Switzerland and even Germany, which has a case fatality ratio of just 3%. So I think these lockdowns they won't be at every flu season. There will be herd immunity, as you must have heard about, that if 60% of the population is infected, then the virus mutates and automatically others get immunity. So this lockdown was essential mainly to reduce the mortality rate, death rate, as well as to what they call it as flattening the curve, which means the health care capacity is limited. And for a country like UK, which is a smaller country compared to India, then if everybody got infected and everybody's put in a hospital, there wouldn't be enough ICU beds, there wouldn't be enough ventilators to take care of the population. So that's one of the reasons. So I'm sure that this lockdowns won't be for every spike or every surge, but definitely to a point where we're not seeing, if you have good testing, if you have good contact tracing and quarantine, I think there won't be a need for a lockdown in December. That's what I think. Let's watch. Another question we have here is that we have learned that NHS reduced its funding to homeopathy. Given the success of homeopathy in epidemics, does NHS have any plans to utilize the services of homeopathy? According to what I know, at the moment, no. The answer is no. Because as you know, that even hydroxychloroquine, which is a recognized drug for malaria, was also not prescribed for use. They said it can only be used in clinical trials, because that's how the NHS works. We have strict guidelines around prescriptions around dissemination. So again, with homeopathy, if there's very good, strong evidence about certain drugs working in an epidemic, I mean, why not? I mean, this is something that the homeopathy community should come forward, show published journals, and even make it available as a prophylactic, if not as a treatment, for people who haven't had it, if there's good enough evidence. So at the moment, it's not, but any new what do you call intelligence is welcome by anybody, even the British Homeopathic Society. What else? There's a question here around how hydroxychloroquine acts as a remedy for COVID-19. Very, very good question. Now, the answer to that is they're studying it at the moment. Now, what happens is, I mean, hydroxychloroquine normally it's an anti-malarial drug, or normally used for anti-malarial, so that it acts on a cellular level, reduces the impact of the parasite, multiplying in the body. Now, I'm not the best person to answer that because I haven't used antimalarials as much in the past 17 years since I've been here. But I think one of the things, what they noticed was that so a body develops a viral load as soon as you get a viral infection. And what hydroxychloroquine was doing in certain patients was it was reducing the viral load. What is the mode of action? What is exactly the scientific method? I wouldn't be the best person to answer because it's still in clinical trials. But if it's going to work, or if it shows significant results, then it may be used as a prophylactic as well as in management of COVID-19 in the future. We don't know that, but we'll see how it goes. Now, there's another question here around, has herd immunity worked in the UK at all? Answer is yes, in the past, for different strains and different viruses. As you know, measles, mumps, rubella, PPV, which is a pneumococcal vaccine, including to a certain extent SARS. I wouldn't say SARS directly, but for winter flu. So for the past infectious diseases, the herd immunity has absolutely worked. I mean, there's no question about that. And why we are seeing lesser variants and lesser strains is because I think the human race has actually overpowered the virus, or whatever mutated virus we had seen in the population. So the answer is yes, it has seen, the herd immunity has worked in the UK, but not for COVID. Sorry, if your question was directed just for COVID-19, then no, it's still an observation. As you know, this is a very new, fresh pandemic, and only months will tell in the next 6 or 8 months what happens and how the virus mutates. I'll quickly take another question. Is even after corona testing comes as negative after a month, so are there new cases coming up again, and how do we understand that? I'm not sure if you're asking about the same person, because if it's the same person and if the person is tested negative, that means the person has not developed immunity to coronavirus, which means they have not created antibodies enough in their body. So there's a chance that they may get infected. So unless you get infected in the current times and you develop antibodies, I don't think you have achieved immunity. So I think it's down to the testing. So there are two types of tests. There's an antigen test and there's an antibody test. The antigen test is a throat swab, which actually is tested in the labs, and if you're positive or not. The antibody test normally helps whether you have developed antibody or not to the virus. So let's get another one. There's one here around, any HCQ guidelines followed in the UK for prophylaxis? So the answer is no, not at the moment, not for COVID-19. Obviously, HCQs is used as a prophylactic for people traveling to tropical countries. So it's given to patients who, just as a protective against malaria. But no, at the moment, no HCQ guidelines for COVID-19, because that's the clinical trial that's underway that I mentioned earlier. And if you follow the clinical trial, then on hydroxy, which is the principal trial, then that might be the best way to find out. Another question here is, we have heard about putting COVID patients on ventilator. Is making the patient's condition more worse? Is that true? No, I don't think that's true, because you would only be put on a ventilator if your lungs are not, if your oxygen saturation drops. So if your PO2 levels drop below 90 or below 85% and you're struggling to breathe, only then you're put on a ventilator. So it's not true that you get worse when you get on a ventilator, but when you're on a ventilator, there's a lot of care that needs to be taken. There's a care for the trachea, there's the endotracheal, the ET tube care that you have. You need to look out for hemorrhagic spots, oxygen saturation, because the patient is completely unconscious. Turning patients over on their front and back, all these factors collectively, and of course the patient's resilience and immunity and how the patient responds is linked to the patient recovery. So I don't think that's an issue. The next question I'll take here is, why is COVID-19 dangerous for diabetic patients, given that it's a respiratory disease? That's a very good question, actually. Now, the thing is, uh, people with respiratory, obviously, and with diabetes were highlighted as a high risk group. Now, what happens in people with diabetes is that people with diabetes have got, not all of them, but many of them have developed neurovascular damage. Now, by neurovascular damage, I mean damage to the nerves, damage to the blood vessels. And what happens is this leads to a weakened immune system. Plus, if you have a high HbA1c or high blood sugar levels in your body, you're perceptive to infections, secondary infections. So a person with diabetes who has a weakened immunity, who may not have a good sugar control, and gets infected with COVID, there's a high chance of a secondary infection like pneumonia setting in very quickly. And pneumonia, as you know, it's basically collection of water in the blood and water in the lungs, and which kind of leads to other complications, because once you have infection in the lung or in a body, your organs are immediately at risk. So you need organ support, you need antibiotics, and then that puts the patient more at risk of complications rather than recovery. So I think that's why diabetes was highlighted as one of the high risk um, conditions. Another question here is, I think I got the virus. What should I do? I think it depends where you are in the world. I think whether you're in Europe or in, but what it is in your country, you would have, there must be some guidelines available from your healthcare industry or your healthcare hospital or your GP. Normally, your first call is how well do you feel? Are you are you really sick in a sense? How much fever do you have? How much cough do you have? Are you having very distressing time at home where you can't take care of yourself? Have you collapsed? Is your fever really high and persistent? Now, if you're not well enough to look after yourself, then you need to call a healthcare professional immediately. The reason is that some people can, as depends on the age as well, that if you're young, you are more likely to have a less severe case. So even if you have the virus, you may not even present with any symptoms. And if you present with symptoms, it may not be severe enough to cause any complications. So depending on where you're in the curve, you need to either contact the healthcare provider or take complete isolation. So if you think you have a virus and you haven't tested, I would still advise to completely isolate yourself for 7 days from all loving people around you at home or work or wherever. The reason is that if you think you may have virus, you may as well transmit it. So you need to take all precautions and do it symptomatic management. So if you have fever, take paracetamol, observe how it goes. But if your respiratory distress continues, if your cough continues, I would call a healthcare professional immediately to get some guidance. So the next question here is, I met this bird at the pub the other day and we had a jolly good time that night. Long story short, I woke up with a red rash on my junk. Is this corona? Most likely it is not, but I would go and just call your medical professional just to check what it is, because if it's a rash, then it could need some kind of antibiotics or some kind of medication. I wouldn't be able to tell what it is without looking at it. But and the other question is obviously cross transmission. That the more you contact other people who may have had a virus, the more chances of you getting it. So you got to be careful in these times that you need to. Well, the only way to find out whether you or the others have an infection is to get tested if you can. If you can't get tested, then just isolate yourself, protect yourself. Make sure that if you present with any symptoms, contact everyone you know and let them know that this has happened so they can look after themselves and the others as well. So we don't know whether the others are infected, but got to take care. The other question here is a good one on plasma therapy. So at the moment, I didn't mention it, but there is another trial that has started around convalescent plasma therapy. My view is that if it works, I think absolutely it should be administered for, especially for the people in ARDS, which is acute respiratory distress syndrome. I've had whatever studies I'm reading from China and others with 5 cases, 10 cases, it's showing good results. Now, one thing you got to remember is that an immunoglobulin therapy is extremely expensive, is extremely in short demand, and it is used for patients with severe immunosuppressive disorders. So if you don't want to use immunoglobulin therapy, then plasma convalescent therapy is probably an answer if there is good enough evidence coming forward. You never know. We should watch this. We should watch the clinical trials and the results. And if it works, then I would say guidelines will be coming out on that very soon. So there is a trial underway if you look on the internet. So there's a question around post-recovery of COVID-positive patient. What is the follow-up protocol? So at the moment, it depends whether you're treated in primary care or whether you had a hospitalization or whether you had a hospitalization and you were in critical care. So it was very important for us to give patients the guidelines that so basically, if the patient got retested and came out as COVID negative, like our Prime Minister Boris Johnson, who got retested and he was told that now you're COVID negative. Now, obviously, for him, the guideline was complete recovery physiologically. His risk of transmission was low, but he was told not to obviously make social contact with his father, his partner, and other people. So the advice for any person who's sort of post recovery, whether from a hospital or from other places, is I would say a 7 to 14-day window, depending on where they are in terms of their management. So if the person has had COVID for 7 days and now their symptoms are getting better, if they stay away for another 7 days from people, I think at the end of that 14-day, and if they don't have any symptoms, their viral shedding is stopped, which means they're safe to kind of go about their activities in the social isolating and social distancing world. So not completely chatting and talking to people. But it's very important for people to understand what stage they're in, what days. And of course, if you want to read about the guidelines on the UK COVID-19, so we don't have post-recovery guidelines, but there are guidelines around what patients should do if they contract COVID. So go on our website, which is knowdiabetes.org.uk. It is KNOW, diabetes.org.uk. This is our website in our Northwest London, where we're giving some guidelines to patients about what to do if you've had it and for post-recovery. There's another one here is around plasma infusion. And the question is plasma infusion with antibodies found to be a treatment and is it effective? As I've said before, yes, there is a convalescent plasma therapy where you take the infected person's, post-infection, the plasma, which is because the plasma has antibodies, and you inject 200 ml of it in a patient with COVID. Recent studies have shown it is effective. So yes, the studies are underway. There's a high possibility because it has got live antibodies. I'm sure it'll be very protective of people who are extremely severe with acute respiratory disorder. And the question is about when do you see it coming to India, the blood or plasma? See, I'm not sure if there are trials underway in India at the moment. Maybe it's best for you guys to find out. But if there are trials underway, then I would just follow it up. And I'm not sure when it's going to come. I'm not sure when it's going to come in UK as well because the trials are still on. So we'll watch this space. There's another question here, Roman. I filed for EDD and I'm still working. So for going to work? What's an EDD? Is there anything, One Life Man? If you can tell me what EDD is, I'll let you know. And otherwise, I think it was good chatting with you all. So if there are, and I'm really thankful for all your helpful comments. I'm really thankful for you to join this conversation. And I'm really also thankful for you guys to doing the right thing, because some of you are healthcare professionals, some of you could be students, some of you are professionals, some of you are maybe patients, who are working on it. So it is very important right now to maintain. So there's a good question. It's kind of linked to what I was about to say. It's about immunity. How can one ensure herd immunity while keeping the mortality low? It's a complex question, but the short answer to that is herd immunity, only time will tell, how the herd immunity is developed. And how to keep the mortality low, it's obviously giving the right care at the right time for people. So I think I'll just end today's talk by saying that thank you very much. Keep doing the good work. Make sure you follow the guidelines and principles. Lockdown is essential and is important at this stage. Ensure that you become an advocate for others. You guide your own family, you guide your own colleagues and professionals to tell them how important it is to manage COVID-19 in a current crisis. What we can do is, within 3 or 4 months' time, I'll request Dr. Ravi Doctor to have a follow-up webinar where we can revisit our experiences from a healthcare professional point of view, a patient perspective, or just a common person's perspective. And we'll reconvene our discussions to take this forward. So I think I'll end this conversation there if there's nothing more to discuss. But thank you so much for joining. And thank you, Ravi Doctor, for inviting me to speak. I hope you got a flavor of what's happening in UK, Europe, and internationally. And hopefully stay safe, I would say, and take care of yourself. Okay? Take care and goodbye. Bye for now.